So I will stop my share and Dr. Sganga will turn on his screen share. We're at 154 participants. Thank you for being here.
All right. Thank you so much for the intro, Mr. Sogo. So I guess before I get started, I want to give a big thank you to you. Mr. Sogo, you're an incredibly influential teacher in my life, and I'm delighted and not at all surprised to see that you are still, being innovative and coming up with new ways to reach students in ways that are, far and beyond what you expect from a high school curriculum. And to everyone else who's here, yeah, thank you so much for coming here and listening to this talk. So I'm going to shoot for around 30 minutes of content on my end. Like Steve mentioned, there's going to be points along the way to ask questions. Please do that. I'd much rather answer your questions and hear from you than listen to myself talk this whole time. And yeah, so with that, I'll jump into it. The title of my talk is autonomous surgery in the lung and the brain. So I'm going to talk about some of my PhD research as well as the work that I'm doing right now. But before I get into that, let's see, I'll talk a little bit about my background. So I graduated from LBHS in 2009. I'm going to seem like a really long time ago for a lot of you in the audience. It doesn't feel that long ago to me. But I guess I was thinking about some kind of context of what was happening then. One fact I thought was kind of interesting was I was in high school when the first iPhone came out. So definitely kind of dates things, but a lot's changed since then. Well, after high school, I went to Duke University and I studied biomedical engineering. And so when I was there, I spent a lot of time thinking about whether or not I wanted to become a doctor or not. I ended up deciding to stay on the engineering side and work on medical technology instead of becoming a doctor. But I think I've really kind of always, part of me wanted to be able to perform surgery. Right out of Duke, I went to work for a small company called Flex Partners down in San Diego. And what that company did was they talked to physicians who were frustrated with different parts of procedures, and the engineers over at Flex would, invent new medical tools. And so a lot of it was kind of mechanical in design. So think about kind of like a new knee implant or a new catheter. And, they'd prototype different, devices, and then they'd file IP and kind of ship it from there. So that was really fun. Spent a year there. Kind of realized I wanted to get a little bit more education and figured that the, cutting edge technology was going to make a bigger impact in healthcare. So that's when I started a PhD at Stanford. And I was there for 5 years from 2014 to 2019. And I was in the Department of Bioengineering. And when I was there, I studied surgical robotics, which you're going to hear a nauseating amount about today. And finally, so after graduating in August, I went to go work for a life science automation company. It's a little startup in this kind of VC incubator called Playground Global, which is an awesome place. Tons of startups and kind of 3D printers and robots walking all over the place. But while doing that, I was also starting this company that I'm now full-time at, and I'll share that at the end of this presentation. All right, so that's a brief history, and now to get into my research, which kind of jumps right into the motivating, I guess, ailment for my PhD research was lung cancer, which is a really tragic disease. It's the #1 cause of cancer-related deaths worldwide, partly because it's so prevalent, but also partly because when you do have it, it's extremely deadly. And part of what makes it so deadly is that it's often caught quite late. So kind of when it's local in the screen here, it means it's just a small cancer that's contained within the lung. And you see that people actually have still low relative to, a lot of other diseases, but relatively high survival rates. But once the cancer spreads to more distant parts of your anatomy, then the odds of survival, drop off precipitously. So one way to help improve outcomes of this disease is really to focus on catching it early. And the way that you diagnose, The way that you diagnose it is with bronchoscopy, so I'll talk about that later. But the kind of other factor here that plays into getting tested for diseases, and actually we're seeing that with this COVID pandemic, is that the healthcare system is resource limited, right? We only have so many doctors, and procedures are really expensive, and there are only so many hospitals, and it's never convenient to interact with the healthcare system. So one forward-looking way to solve that is to use automation, to use robots to make our healthcare system more efficient and easier to access for the people who need it. So I want you to, I'm guessing quite a few are familiar with self-driving cars. You see a lot more of them up in Northern California, but there used to be a lot of press around the fact that Uber and Google will have these self-driving cars who will make it so that we can all get really cheap and safe rides wherever we want to go. Well, we'd love to take that technology that developed in the spirit of self-driving cars and apply it to surgery, right? And in doing so, make surgery cheaper, safer, ideally more accurate, and really more accessible to more of the population. So now let's go back to the lung cancer specific case. So I'm going to walk through a couple of the steps that you as a patient might go through if unfortunately you're trying to determine whether or not you have lung cancer. So usually you'd present to your physician with some kind of symptom, or maybe this is just a routine scan, but what they do is they take an X-ray of your chest, and on that X-ray they might identify some kind of a lesion, but it's something on that scan that they don't quite understand. So that's boxed here. So you know very little from this scan other than the fact that it's there. So once you notice that, the next thing that you do is you'd get a more detailed scan. So this is called a CT scan. And what it is a bunch of X-rays along your torso in this case. And what software can do is they can stitch all of those scans together to take these individual two-dimensional images and extract a three-dimensional shape from it. And so there's going to be some audio, but so this is just one representation of the airways of the lung, and you can kind of see that it's this tree-like branching structure, and you can extract that information from the CT scan. So imagine you have kind of that extracted structure that you got from the CT scan, and now you're imagining, okay, it's relative to where we saw that lesion in your lung, we can kind of map out a course to get there. So it's kind of like the Google Maps analogy of how do I drive to this location, and you can starting in the trachea, so your mouth's up here, you can go down your lungs, and in this case go up into your upper left lung, where you would try to sample some of that tissue. You want to figure out what you're actually dealing with here. It could just be an infection, or it could be cancer. So once you kind of have your roadmap laid out, the next thing to do is to drive there. And so this is a picture of an example bronchoscope. It's a long flexible tube. This is maybe 3 or 4 millimeters in diameter. And at the tip of it, there is a camera and a light source that they use to kind of drive. And it also has a lumen through it, a hole through it, where you can pass a needle or a brush or clamp to sample that tissue once you get out there. It's not too easy to do this, partly because you're still breathing during this procedure. You're sedated, but you are driving on road that's constantly moving underneath your feet. So a big challenge to automating this is being able to adapt to your body moving as you move into it. So maybe that's a good point to pause and open up the field for questions.
All right, so I'll ask the first question, but students, you should be typing questions into the chat, and the teachers will be monitoring those questions to pass them along to Dr. Sganga. So you're trying to get a sample of cells from that lesion, is what you called it. And so I asked you this before, but in the old days, was there a way to get that sample?
Yeah, not easily. So a big shift in modern medicine has been the move towards what's called minimally invasive surgery. So that's putting the smallest possible tool in your body and the smallest possible cuts in order to access different parts of your anatomy. So before, way back when, first of all, you wouldn't really diagnose all that much, but you would do open surgery. You just, open the chest up and then look and see what's there. There's other procedures where you can, stick a needle from outside your chest and poke it through, your skin and get in between your ribs to get to your lungs to sample some of the tissue, but that's really not pleasant either. So going through the airways of your lungs is actually the least traumatic way to get to this site.
Okay, and okay, so we're starting to get some student questions. Keegan Thomas has a nice question. So talking about automation and how that can help make healthcare more accessible and affordable, but wouldn't these machines be really expensive?
Yeah, it's a great question. So the goal is that the machine will eventually pay for itself, right? That there's this upfront cost, but it offers value over its lifetime such that it becomes, economically viable. But it's a great point, and right now the robots are frankly too expensive. So they haven't offered as of yet too much benefit to the healthcare system. So I think that's going to be an exciting direction for surgical robotics to move in. That being said, healthcare is really expensive. So there's actually quite a bit of room for an expensive piece of equipment to still offer value.
All right, here's an interesting question. It's duplicated. Trey Evans and Luca Elganian are saying if the surgery's been done by a robot and it goes wrong, who's legally at fault?
Yeah, that is an extremely important question and even more relevant to the work that I'm doing now. So there is kind of, in surgery, there's, and in healthcare, insurance and liability is an enormous industry in and of itself. So the physicians have their own malpractice insurance, the hospitals have their kind of, insurance, and there's also kind of the device liability. So if we take a really simple case and imagine, just a scalpel, for instance, that, would be used in a typical surgery. If for whatever reason, that scalpel kind of like breaks or shatters and causes some kind of issue during the surgery, that's going to be the device manufacturer's fault. Everything else, and so kind of like if you were to look at the distribution of who's at fault for complications and procedures, typically the device side is really small, right? There are usually very few complications that can be clearly blamed on the device, and most often it's the physician who's at who has at liability here. If we move to more forms of autonomy, then what I expect to happen is the liability of the device manufacturer to increase significantly. However, there's still going to be, a delicate balance between the physician and the device, because if something goes wrong with the device, the physician still needs to take action, right, to fix that. So there's going to be some kind of balance there.
Yeah, okay, very good. There's one more question here from Luke Johnson, which I think is a good one for us to consider. If there was a poll of opinions, what do you think would be a common recurring opinion of patients towards this automated surgery?
Shockingly positive. And so there is a pretty widespread belief, which I've found kind of funny recently, that people really trust robots, to the point where they found that the Da Vinci robot, so this is the most famous surgical robot. It's the really big one with arms that have little pinchers, and that's sold around the world and has been quite successful and is used in a lot of procedures. One of the biggest driving forces for that robot being sold is that patients prefer hospitals who have the robot. So it really is a surprising force that patients prefer robots. Once robots start making their own decisions, maybe people will start getting a little bit more squeamish. But I think we'll have to just, the robot manufacturers and designers will have to just make a compelling case, right? You just have to convince people that this will potentially help them.
Okay, very interesting. All right, we'll continue with Dr. Sganga's talk now. There'll be another pause point in a few minutes where you can ask some more questions.
All right. So, what does the future biopsy system look like? I'm kind of glossing over what it looked like before, but it was a manual device that the physician would hold as it was basically driven through the airways of your lungs. But recently, one of the first robotic bronchoscope devices entered the market, and that was delivered by this company called Auris Health, which is now part of J&J. And so this device is shown here, and instead of a human holding it behind this, it's actually a robotic arm that's holding it. But it's the same kind of concept where you have a light source at the end, a camera, and a lumen to pass tools through. To give you a little sense of what's happening kind of outside the patient is we have, the physician here is now looking at a heads-up display and holding what's effectively an Xbox controller. And the robot behind the physician here is actually pushing the device into the patient's body and actuating it. So as the physician, presses buttons on the Xbox controller, that robot is then performing the actions in real time. So it's very much like a first-person shooter video game where they are, steering this thing and driving into the body. The way that they move it in the body has to do with these wires that run down the body of the device. And as the physician, pushes on that remote control, the robot tugs on the wires that run through the bronchoscope here. And by pulling on that wire, it's kind of like pulling on the reins of a horse or like the strings of a puppet, it curls the tip of this device. And that's how the physician chooses which airway to get into. All right, so here's another question point, but I'll just kind of let this video loop.
So the light is essential because otherwise you'd see nothing. And there's a camera, just a really tiny camera in there that gives the physician, I guess you're going to show some of that, huh? What does it look like from the, what does the actual data look like, the images look like from this device, huh? Okay, cool. Very good. All right, I'm looking at the chat. How long have these things been in existence? Do you know?
So manual bronchoscopes for probably since the 80s or even the 70s.
Okay.
And so before, what they would do is that they might have been rigid, and they would have rather than a camera at the tip of the device, kind of like a light channel that would then kind of image, outside the patient. And so they're much more limited, but scopes have been around for a while. This bronchoscope got FDA approval about a year ago.
Oh, okay, very new technology. All right, good. We've got some student questions now. Trey is asking, is this the robot that did surgery on a grape? I don't know that story.
So the robot that did surgery on a grape, I'm pretty sure you're talking about some of the promotional material from Intuitive Surgical. So that's the Da Vinci robot, where their whole thing is they have these like really tiny grippers and like little wrist joints, so that the surgeon from a console in that room can do really fine, small, procedures or motions. So they could probably, sew up a grape. I think that's what you're talking about.
Okay. All right, here's a good question. It's a lead-in question. Um, is your research focused on the mechanics of the robot or on the programming?
Yeah, great question. I focus on the programming. So my research was sponsored by Oris, and so they kind of offered me an early prototype of the robot in the beginning, and then later on, I used their actual, kind of FDA-approved robot. But I avoided the mechanical side of things in this case and just focused on the software, which I'll explain, I guess, as we move forward.
Yes. Okay. And I neglected to say that was from Elliot Bergerson. And uh, okay, I think we'll go ahead and go forward because I think we'll have more data on this as we go. Oh, okay. Well, maybe this is a good question from Sterling Radisay. Well, we'll do this now. How does it find its way out with no rear camera, no backup
Yeah.
camera?
Yeah. So one thing that's worth mentioning is that these devices are really flexible and compliant. So they are naturally you're like they will bend against the airways of your lungs. So there's kind of some inherent safety involved with them. So yeah, I guess I don't know if I have anything that clearly shows it, but kind of like you can only control the tip of this device. Like the whole length of it is just along for the ride. So it's going to be bounced off of, the different airways in your body so that when you retract, all you do is let it go, you just relax the tip of it and then you just pull it out.
Okay, excellent. Um, okay, we're going to go forward. Thank you for your questions. There's more questions than we have time to answer. So I'm going to let Dr. Sganga go forward. Thank you for the questions. There'll be another chance to ask questions in a few minutes.
Okay, so I'm going to talk about kind of what really was my research and kind of what I worked on in order to try to automate this procedure. So I worked on the localization problem, and so that problem means figuring out, at every point in the procedure, where are you with respect to that preoperative scan? So I ended up, this was a harder problem than I think I originally anticipated when I started this project. I ended up doing 3 different approaches to solve this problem. I'm only going to talk about the one that worked here. The next part is once you know where you are, I mean, you have to drive. So to get from point A to point B, you need to figure out how to move this awkward device. So I'll talk a little bit about the algorithms that I worked on to help drive this thing. Finally, I put it together, the driving and the localization, to result in a self-driving feature of the lung, or feature of the robot inside a plastic lung. And then I'm not going to get to this in this talk, but I showed how the localization algorithms actually applied decently well to data collected from human cadavers. All right, so now to get to the localization question. So this is, figure out where you are with respect to this map on the left here. So when you take the scan, you figure out, okay, maybe you want to go to this target. Do you see my mouse, by the way? Is this highlighting anything? Okay.
Yeah, the mouse
so
is visible. The mouse is visible, Jake. Yeah.
Great. So kind of where you want to go, and that's great. You have this 3D model of it, but when you actually get in there, you're looking at something like this, which is pretty challenging to figure out. Even for a human, it's kind of tricky to figure out which of these airways corresponds to what's happening in this scan over here. And now the question is, how do you get a computer to do this, right? If you were trying to code something up, how would you try to kind of go from this image on the right to figure out where you are on the left? So to kind of lay out a little bit of I don't know, I guess some terms here. So imagine that you have the real, lung phantom here. This is the plastic lung that we use that's kind of life-sized. And you have your bronchoscope inside of it, and it's at some position, right? I'm calling that X at some time point. You have a camera at the tip of that device, and from that camera, you get an image that looks something like this, right? So this is a camera image taken at that position at that time point. You also have the CT scan. So it turns out that with this CT, this kind of three-dimensional representation of the lung, you can have an estimated position, and based off of a program called OpenGL, you can render what you'd think it would look like if you were inside the lung looking from that position there. So this is kind of a simulated image of the real one. And this is what it looks like to have kind of a virtual view flying through the lung here. So you can get a pretty accurate representation of what it might look like when you're inside there. And this is going to help us kind of try to solve this localization problem. And some people tried this before, but it's a hard problem to figure out. And what people did before is they compared, the real camera view to the simulated view. And the goal is when these two images look similar, then then you know where that real image is taken. You know where your real device is in the body. The problem is that those techniques required kind of manual coding of the computer vision algorithms. So very briefly, I want to talk about kind of what deep learning kind of offers. And I'm guessing some of you have heard of it, but this is just a really high level conversation about why I use deep learning to tackle this problem. So if you look at an image, in this case, an image of a cat, and let's say you want to come up with some computer program that could tell you whether or not there's a cat in the image. Well, the computer sees this matrix of values of light or color intensity values. And so whatever algorithm you write needs to process this grid of numbers and tries to give you an answer of whether or not this is a cat. So let's say maybe you actually came up with some really incredibly painful program that looked at everything and maybe saw the outline of this cat. You're like, okay, great, I've got a program that defines where a cat is. Well, if you see a different picture with a cat that's in a different position, then I'd say odds are that's going to ruin or break the program that you wrote before. And things like occlusion, stuff like that. So it's a very difficult problem to try to predict what you think the camera will see and determine in a function how it should react. So I guess another way of saying this is in normal computer science, what you do is you write a program and you put data into it, and then out pops your answer, right? So this is kind of what you expect. This is what you do in your chemistry class and everything else. And what machine learning offers and deep learning is if you start with your data and the answer to the question you want to ask, the output of that is the program. So then later on, you can use the program and new data to get new answers. Let's see. So in this case, you could have a ton of data for different images, and I use a convolutional neural network, which is a type of neural network that's specifically designed to handle images. All right, so here's another, point for questions.
Okay, once again, students, try to put something in the chat that we can ask Dr. Sganga. So my first question is, when you were showing that simulated pathway through, it looks really like a video game. And are you using things that were invented for video games? Is that part of this technology?
Yeah, it's actually extremely similar to what's used in video games. So a lot of the I mentioned the OpenGL. It's a lot of these exact same tools that try to figure out, if I had this three-dimensional object and some light source, what would that look like, right? And then making it so that if I move the light source or I move my perspective, it can process it really, really quickly so that you could actually have a real-time display of how that view would change. And so that's very similar to how a video game operates. In fact, video games are incredibly useful for deep learning because you can simulate a lot of these things that would be much harder to show in real life. I guess I'll get to that in a little bit.
Okay, that's upcoming, huh? All right. Question from Luca Elganian. Is there a way for the robot to navigate the airways using stimuli other than pictures? Could you use some other kind of sensor to guide it?
Yeah, that's a really good question, and something I glossed over in this. So you can use X-ray images. You don't want to use that too frequently because you don't want to add too much radiation to the patients. But with an X-ray image, you'd see from the chest perspective where the device is relative to the anatomy. Although you also can't really see the airways all that well in an X-ray. The other device, which is part of the Auris system and part of the newer bronchoscopes, is a position sensor. So it's a electromagnetic sensor. If you have a kind of like a beacon or a home base at the patient bedside, you have a little sensor at the tip of this device, and it will tell you where in three-dimensional space the tip of your device is. Now, mapping that three-dimensional point in space, like, oh, you are 10 centimeters to the right, or like on the x-axis, and a centimeter along the y-axis, figuring out how that relates to your preoperative scan is really challenging.
Hmm. That sounds a lot like Natalie Pueyo's webinar was saying, where is this strawberry cart in the field? And she used the DPS technology to get this signal. Now I know where I am in the strawberry field. So now you're saying you could use a similar system to say, where am I in the lung? Excellent. Yep. Okay, Taro Sakai is wondering, well, he's saying, I feel like this device is closely related to the colonoscopy device, except used for a different task.
Yeah. So it's spot on. So they just call these devices by slightly different names depending on the procedure. So in the colonoscopy, it's a colonoscope. In the lungs, it's called the bronchoscope. It's this general class of endoscopes. So they're just the long flexible devices with a camera at the end that you put somewhere inside the body.
Excellent. And then this may be a lead into your next part. Where do you get the data to train the program for the lung pathway?
Perfect. That's a great lead in. So I'll take it from there, I guess. So what do you train on? So this is the most important question that you should ask when anyone talks about a machine learning algorithm or anything like that. The most straightforward answer is you want to train it on past procedures, right? So you ideally want your sequence of images that you've taken before, and in this case, a sequence of simulated images too. So what I did was I took the Auris robot and I drove it around the plastic lung. So here it's shown encased in silicone. So that was to give it a little bit more lifelike of stiffness as you moved through it. And so I just drove around for 30 minutes or so and collected thousands and thousands of images to try to start with a training set. The problem with this procedure is you need to label your data. So in that case, for each one of these images that I collected, I needed to know where in the lung I was when I took that image. So I made a little video game where I could fly around in the virtual view, and I tried to line up the virtual image with the image taken from my recorded procedure as well as possible. And once I got those as close as possible, I would say, okay, this is where this image was taken in the lung. That is a huge pain in the butt. I spent a lot of time doing that. So, and this is a little bit, maybe a more general point for machine learning stuff, is that labeling data is a tremendous task. And having a strategy is really important. So an alternative, which is kind of led into before, is to use simulated data. So this is very similar to what the self-driving car companies do. Is they drive their cars in actually a simulator based off of Grand Theft Auto. A lot of them do. And the idea is you can simulate, hours and hours and hours of data in a second, right? Whereas actually collecting that data in the real world is extremely expensive and difficult. So ideally, you kind of want to use either a little bit of both or lean on simulated data when you need to. One problem with you train on simulated data is that it's not exactly the same, right? So if you're really good at knowing where this image on the right is, it's not certain that you're going to know where the image on the left is, right? It's and in fact, these neural nets are pretty good at getting confused by differences like that. So the way that what's that?
Can you go back to that slide previously, Jake?
Yep.
So the image on our right, that's the simulated, perfect,
Yes.
looks really nice. And the image on the left is a real photo
Yes.
from a bronchoscope, and it's much grainier. And so you have to be able to say these are the same, and that's hard, huh?
Yes. Yeah, and there's kind of, there's like surface features, there's kind of speckle, so it's tough to especially for a camera, it's really tough to make something simulated look exactly like a real life thing. So if they don't look exactly alike, the odds are is that your machine learning algorithm will not perform that well on the real data. So one thing that you can do is you can mix up your simulation as much as possible, right? So it's like, okay, well, like instead of just trying to make it look exactly as similar to the real thing as possible, I'm just going to throw everything at it. I'm going to move it all around. I'm going to change the light intensity. I'm going to change the color. I'm going to add noise and all stuff like that. And it turns out that this is extremely effective for helping your algorithms handle the real data. Okay, so the next part is you have the data, and so the part that I kind of mentioned before is you have data and you have the answer, and then that's how you get your function. So now we have the data. You have to figure out, what question are you going to ask the system when you're in there? And this is kind of the third approach that I took. But if you look at your CT scan, you can imagine that your airways are just kind of little lines here, and you kind of have your path to your target, the tumor here. And these are kind of the images that you'd see as you went along that path. So the question that it turns out was unintuitively the best thing to ask is just asking the algorithm, which airways do you see, right? So if you assign an ID or a name to every single airway, which doctors do to some degree, like the first one's the trachea, the left one's your left main airway, the right one's your right main airway. But if you give an ID to all of these different ones, then you can ask the computer, hey, which of these IDs are visible in this image? Okay, I'm skipping over a little bit of that result just to get to the actual driving part, but the answer is that question actually worked pretty well. I think this is actually a decent time to ask another question, although given how much time, I think I'm going to skip over and just get to the driving part. All right, so let's say, so now that we know where we are, the next part is figuring out how to get from point A to point B. So here's some of my work that I did to telling the robot to go from get to point 1, then to point 2, then to point 3. It has no idea that there is a block in the way. So if you had some kind of like preset model, you'd expect that the robot would go forward and then curl to the right to reach point 3. But you'll see in this video is that as it moves through the environment, it gets deflected by this kind of fake representation of the vessel. And the robot has to adapt to the fact that it is now, curved to the right, and so it has to bend back left to get to that point. So that's a little bit of kind of how it adapts. And now I'm going to talk about, putting it all together. So we'd scan the patient. We would identify the targets that we want to move to. We would simulate a bunch of images along that trajectory and train a network to do that. Then we would use this control loop. So all this is showing is that the robot spits out a camera image. We'd put that camera image through our trained neural network. That network tells us what airways are visible and roughly where we are. Then based off of what we see, we compare that to the airways that we want to go down, and then we move towards the airway that's on our path to our target. And then we move the robot sends more images. So here's an example of this working where this is a representation of a three-dimensional scan. I pick a point. I'm actually not going to go to exactly that point, but I'll show you here. And now here is the robot driving in the Phantom, and it is doing this all autonomously. So in this case, we are moving to, okay, well, I guess I'm just driving this. On the left is what you're seeing from the front of the camera. On the right, you see this light source, and that's where the device is actually moving in the lung. And it's supposed to highlight it, but its target is down here in the lung. So again, so we're going down here. This is what it's seeing, and it's driving itself as it moves through the lung here to get to its target. And it's doing all of this on its own. I was the one manning the camera here, and it was pretty exciting. So that's one target, and you can go to.
That was 5x speed.
Yeah, so I moved it pretty slowly to keep everything safe.
Yeah, but it seemed like it got there really fast.
Yeah, so it turns out these procedures don't last long.
Okay.
For the actual driving part, it's pretty straightforward. So now let's say you want to go somewhere else. It can. Oh, okay. Now I remember. Okay, so my videos are a little bit mixed up from what I had before, but it could actually pull itself out and go somewhere new. But here is another video of it driving itself to the different side of the lung. Again, on the left, it's the image that it sees, and on the right, you can kind of get a sense of where the robot is based off of the glowing light source. So yeah, well, that was where it was highlighted. Okay, so now it's probably a good time for questions. That sums up all of my lung-related topics.
So you were saying it's pretty short procedure. How 5?
Yeah, I mean, 15 minutes.
15 minutes.
If things go, according to plan. Sometimes you might have a tricky time getting to the target, in which case it might take 30 minutes. But for the most part, it's a relatively short distance. So you just have to make sure you get to the right spot.
Mm-hmm. Okay, question from Grace and Joseph. What happens if, when you're trying to get to the tumor, you have to go through a bronchi that's too thin?
Yeah, so this device has a diameter of 3 millimeters. The airways quickly get smaller than that. So for a number of them, you can actually kind of push through them, and they're flexible. So you can get further out than you'd think. And then once you are about as far out as you can go, there's maybe another inch or so before the edge of your lung, or kind of your chest wall. For those things, if there's a tumor out there, you can stick a needle that just kind of punctures through that remaining kind of inch of really small blood vessels, or sorry, airways, to get to that tumor.
Okay, so that doesn't cause lasting damage when you stick a needle like that?
No, not much smaller damage than leaving it untested.
Yeah, or the old-fashioned cut them open.
Yes, exactly.
Okay. Okay. Let's see. Here's a question from Ms. De Leon, and she's saying, as a nurse educator at the high school, I see the advantage for infection control for immune-compromised patients. Do you have evidence of reduced infections with this method?
Interesting. So the robot is new on the market, so I don't know if there's infection rate data on it. I would say it still requires the humans around the robot to follow all the necessary sterile technique and keep the surgical field as clean as possible. So I think in general, more robots will enable operating rooms with fewer people. And in a time when there's a pandemic, having fewer people in any given room is beneficial from an infection standpoint. But for the most part, the procedures of keeping everything super clean and not touching everything, kind of, it still relies on the human to make those right decisions.
Okay, let's let you go forward with your talk.
Cool. All right. So now getting to the next part, which is at the end of my PhD, I kind of had this slide where I said, you can apply this technique to different procedures. In one case, going into the brain, it turns out I'm starting a company now to do that. so my thesis is kind of that in the future for medical robotics, you know, instead of the human being the specialist that you have to travel very far to, ideally that the human and, you know, some kind of piece of hardware in the operating room are the generalists, and they're everywhere, and that you have software that's hyper specialized for a given procedure, and that can be distributed in any hospital around the world easily, unlike the human specialist. So that led to my company, which is a super early stage startup. We're raising our seed funding right now. It's a terrible name, definitely going to change that, but our ambition is, you know, pretty significant of developing life-saving robotics, because one feature of the medical robotic space is that it's actually been pretty spotty in their actual clinical impact. You know, they've helped maybe, and my co-founder and I really wanted to make a robot that made a dramatic improvement to patient outcomes. And so the procedure that we decided to target first, or the pathology that we decided to target first, is stroke. So a stroke, it's a blood clot in the brain. And in particular, so we're talking about ischemic strokes here, and I'm going to narrow it down even further to what's called a large vessel occlusion clot, which kind of on the right, it's when there's a clot in the large vessels, like kind of the first couple branches in your brain. And when a clot, you know, gets lodged in there, the rest of the brain downfield of that is now starving or I guess suffocating without oxygen. So it's the incredibly important disease in the sense that it's the #1 cause of adult disability in the US and around the world. And it's an extremely costly procedure too, because taking care of people who are disabled for the rest of their lives is significant. So the best thing you can do to treat this procedure is, or the two things that affect how well you do after having a stroke, is whether or not you're able to get this procedure that we're about to talk about, and secondly, how quickly you're able to get that procedure. So this is what that procedure looks like in a very, you know, glorified way. What they do is they stick a catheter in, usually starting in your leg, thread it up all the way to your brain, to the site of the clot, and then they stick a stent through it, or have a kind of a suction device, and they literally pull the clot out of your brain. And in doing so, that frees up the blood vessel to supply blood flow and oxygen to the part of your brain that was, you know, previously suffocating. So the results are pretty striking in that on the x-axis here, we have how long it takes from the time of your stroke to the time that you get this procedure. And the blue line here corresponds with the percent of patients who are functionally independent afterwards. So if you get treated in the first hour of getting a stroke, your odds are pretty good that you will walk away from that and, you know, resume your life as normal. But you can see as the minutes tick by, the percent of people who walk away from this unscathed is, you know, dramatically lower. It's about 6 hours out, you have very few patients who are functionally independent. And related to this, in red on this side, you see that the cost to the medical care system is enormous, because you know, as more people are disabled, the cost over their lifetimes really goes up. Not to mention there's quite a few deaths as well along this route. So in order to perform this procedure, you're using these images that you see on the right. They're called angiograms. It's an X-ray image of the brain when it's injected with a contrast agent. So it's kind of like a roadmap. And so the thinking is to apply a very similar technique that I applied in the lung, of training these deep learning networks to figure out where your wire is relative to the anatomy. In this case, it's kind of, you know, the different anatomical vessels are highlighted, and use that to have a self-driving robot that can be placed in these hospitals that don't have the specialists, because only 2% of US hospitals have the specialists to perform this procedure. So we really want this robot and the software in every hospital. And that's really just one procedure on a long list of these that are time critical, and there's a lack of access to treatment. So if you get any one of these things, you'll go to the hospital, but then they'll likely transfer you to the specialist center. So we want to make sure that, specialist level care is available at every hospital. And in doing so, we think that, with our robot and our software, we could do that. All right. So this is right at the end of the talk, but that's it. So thank you.
Okay. This is your last chance to ask questions. The questions so far have been excellent. So thank you all who have participated. So my question is, right now you think hospitals are filled with doctors, physicians. Do you see that the hospital of the future has a large need for like software engineers who are taking care of these machines?
Tremendously. Yeah. Apply that to literally every industry and every problem. I would say that software engineers are going to be critical. So one piece of advice to all the high school students is to try taking computer science 101 when you're in your first year of college, because no matter what you do, having some familiarity will be valuable. And if you do like it, then it really opens up a ton of possibilities for your career. So yes, I think you'll see hospitals become a much more integrated place with not just the healthcare professionals, but also the technologists.
So when did you learn coding?
I learned it at Stanford. So
Really?
I went through all of undergrad, learning a little bit like MATLAB, but not much anything. So my first year in grad school, I took CS 101 with all the freshmen, and being able to graduate is very motivating to learn how to solve your problems. So there's definitely room to self-teach yourself.
Yeah, we have a number of people self-teaching at Laguna Beach High School, and we also have a couple computer science classes now. We've had them for a few years. All right, here's a question from Luke Johnson. Has nanotechnology been considered to use in your operations?
Yeah, nanotechnology is interesting. Got a lot of hype and then didn't really come through. So there is a drug that you can use. It's called a clot buster. It's basically a blood thinner that you can inject into the vessels and then hope that breaks down the clot. But it's been shown to be far less effective than the mechanical procedure. So kind of the nanotechnology that's most effective really are these kind of combination therapies that have an exterior that targets certain locations, specifically in kind of cancer therapies, where they get concentrated where the cancer is, and they have this payload of chemotherapy or something like that. So not too effective here.
And is there any advantage to having a robot that is not on a string, but actually just kind of crawls through and finds it and jump.
Yeah. So there's been some work on that. There is a robot that you can. It's more like a pill, but you can swallow it for, instead of having an endoscopy, so down your digestive tract, you swallow this pill that has a camera and a battery on it, and it just takes pictures as your body processes it. The wire is very useful as a safety mechanism because you can pull things out. So you don't want to leave anything in there. But it is difficult to push things on a wire, right? So sometimes you have to take U-turns in the body, and that's very difficult when you're pushing from a wire.
All right, makes sense. Okay, it is 12 o'clock. I thank all of you participants for being here. I certainly learned a lot. Hope you did too. And I'm giving another webinar tomorrow. Next week, our webinar is going to be about the development of cancer drugs. So it's by a chemist, Andrew Robb. So hope you'll enjoy that one. All right. Thank you very much. And have a good afternoon.
Thank you.
Thanks.
Thank you.
Okay, yeah.
That was super interesting.
and could be potentially life-saving for a lot of people.
Hope so.
Yeah.
So I actually have one potentially very silly question.
Sure.
Are all lungs the same?
No, yeah. So
question.
there depends somewhere in the brain where there are certain parts of it that are very similar, right? Like everyone has, the trachea, and then everyone has two lungs. So kind of probably everyone. So that part's super similar, but the further out you go, the less conserved it is between patients.
Got it.
Which is why that kind of the scan for that specific patient really helps you kind of figure out, like, okay, here's the exact set of roads that we need to drive on.
Got it. And so for the brain robot, would you go in through the leg again as well?
Yeah. So we're hoping to kind of copy as similarly as possible to what the humans currently do. So it's going in through the leg, going up and around the heart and into the brain. And in that case, because we're focusing on the large vessels, it's very similar to like stopping at the trachea and like the break to the left and the right lung, where it's it's fairly well conserved across patients.
I see. And so the idea is that if you could program these robots, then you wouldn't need specialists, but there's always the chance that things go wrong, or once you get in there, you do need a specialist. So is the idea like this is just kind of like a first, maybe this will work, if not, send them off?
Exactly. And so that's why I think the brain is a far better clinical application than the lung. Because in the lung, that's an elective procedure to get a biopsy, whereas in the brain, it really matters how quickly you get this performed. And so if we can offer like, hey, this is riskier, but if we can treat you right now, your outcome will be significantly better than in 2 hours once you make it all the way to where that specialist is. So we don't really we're not planning on replacing any specialists. It's just kind of filling the gap where they aren't.
Right. Or they aren't. So this is certainly better than just waiting and saying, we'll put you on a plane to where you need to go.
Right.
So do you see that hospitals will be the ones saying, we want this technology? I'm wondering who steers the ship. Is it?
Yeah. It's a good question of who the decision makers are. So one thing that I think at the end of the day, it's the hospital who decides whether or not they buy this robot. And when the hospital sends these patients away right now, in a sense, they're missing out on an opportunity for revenue, because insurers pay a lot of money to the hospitals that perform this procedure. And so, it's potentially kind of revenue that this hospital could capture. And then we'll have to kind of figure out that the insurers have a lot to win as well, if we can, have enable fewer people to be disabled. And so I'm not exactly sure how they influence this whole thing, and maybe it's whether it's a payment structure or a liability structure, but they're definitely going to be incentivized to help us get these hospitals.
And I would imagine this would be, after paying for the cost of the robot, it'd be less expensive because you don't have to pay a top physician.
Yeah, so it's going to be way less expensive than and what you need is you need several of these specialists to really offer, like, because they'd be on call all the time. And so there's actually a host of reasons why these physicians aren't already in these other hospitals. And so they've been super enthusiastic about this idea, interestingly. But yeah, I mean, we expect the cost of the robot to be, less than a year's salary of one of these doctors. And then,
wow.
Yeah. And then it would just kind of, from then on, be, I think, a benefit. It's a really simple robot too, I guess, that's required for this procedure. Like, it's, all these doctors do is push and pull on a wire and spin it around. That's all you can do from that perspective. And so the robot can actually be quite small to manipulate these wires.
So could you have a learning robot that could do more, like a self-learning robot, if that makes sense?
Like in a research sense, yes. For our perspective, I think we'll train the algorithms on the previous data, and then we'll kind of set how the robot's going to work, and then we'll demonstrate that. And like if that works as is, then we'll freeze it, and like that's what's out there. And we do like software updates, but we wouldn't we wouldn't let it change too much. The FDA will be difficult enough.
Right. Makes sense.
Is the U.S. leading the robotic surgery, or is other countries doing similar things?
The U.S. is leading. It's a relatively small field still, and I think a big reason for that is they haven't figured out exactly where robots would make a difference. So a procedure where the human could probably do it just fine, and the robot requires that same human to be in that same room and doesn't make the procedure any faster or necessarily any safer. Like it's not quite that compelling. So this is a very this is a paradigm shift of what medical robots have done.
Yeah, paradigm shift. Okay, excellent. Thanks again, Jake.
Thank you so much.
We'll look for updates from your startup and try to follow it. Okay, very good. Okay, take care then. We'll end this meeting now.
Okay,
I'll get you the link for the recording when I have it.
Awesome.
Okay.
All right.
Thanks. Bye-bye.